Thanks, Marielle, for that very kind introduction. So just to start, I have no relevant disclosures to make, and I'm very happy to be here. Sydney is disgusting right now. It's a beautiful city, but I'm very much enjoying the Amsterdam winter the last few days. So today I'm going to take the next 20 minutes to discuss the use of oxygen in critical care. We're going to review some history. We're going to talk a little bit about some pathophysiology, look at what evidence is available for the use of oxygen in certain clinical situations, and try to make some recommendations. So before I start, a little bit of audience participation. So Luke, our gentleman, who I think has had a traumatic brain injury, potentially. So imagine he arrives in your emergency department. Those are his observations. So he has saturations of 94% on room air. He's got a respiratory rate of 24 and shallow respirations. If we had the Good Sam app, we'd see that he doesn't look very well. His heart rate is 90 in a sinus rhythm, and he's mildly hypertensive. And his GCS is 13, with eyes open, mumbling some words, not following commands, and he's quite agitated. So I won't ask you if you want to intubate him, because that was the previous talk, but before we do that, who wants to give him, the options are, and I'm not sure if the Twitter app is working where you can vote on it, but you can give him a Hudson mask running at 6 liters per minute of oxygen. You can apply some nasal prongs, going for a saturation of greater than 98%, or not give him any oxygen. So if it's working, have your votes, and you'll see what the audience thinks. And another question to ask yourself, if his GCS was 14, would this change your answer? So in my talk, I hope to give you some insight into the use of oxygen for critically ill patients. Okay, so, oops, it's not going to work. So moving on to the discovery of fire air. So the lab discovery of oxygen occurred in 1771 when Carl Schuyler, who was a German-Swedish chemist, generated it by heating mercuric oxide and generating oxygen and mercury, which if the video worked, you see that reaction happen. So he collected his gases in a pig's bladder, and he noticed that, and he rightly saw that one of the gases he collected made the fire burn brighter. So he was actually the first one to discover it. Not surprisingly, he later died of mercury poisoning at a young age. So for many years, it's actually Joseph Priestley who's credited with discovering oxygen because he was the first to press. So even in the 1700s, it was publish or perish. So he described it about 3 years before Schuyler actually ended up publishing it, but 3 years after he discovered it. And from then on, as things got off, the value of it was quickly recognized. And in 1798, the Pneumatic Institute opened in Bristol. And they started using oxygen and other gases for the treatment of asthma, congestive heart failure, and a variety of other ailments. And you could, throughout the 18th and the 19th century, you could buy it at apothecaries. So the first cylinders to store oxygen were invented in 1868. That's probably not it. That's just a picture off Google of an old-looking oxygen cylinder. And that made it actually much more feasible to use it when giving a general anesthetic or more portable. And about 20 years later, it was used for the first time in its clinical application in a young man with pneumonia, which is depicted up there in 1885. The famous Haldane from the Haldane effect, who was one of the fathers of altitude physiology study, was one of the first to describe the adverse effects of hypoxia when he led an expedition to Pikes Peak. So at the same time as everyone was discovering how great oxygen was, other people were also discovering its harm. So both Paul Burt and Lorraine Smith were doing investigations on larks and mice and discovering the CNS and pulmonary toxic effects. Now we're up to the present day. I'm not talking about ECMO, but how we give oxygen has really changed a lot in the last 10 to 20 years as well. So that brings us up to the present day. So I was certainly taught hypoxia is bad for you. And when resuscitating someone, assume nothing, trust nobody, give oxygen. And that's probably still very much taught today. And providing supplemental oxygen is fundamental to the management of critically ill patients, both during their initial resuscitation and throughout hospital. But there's increasing interest and research into some of the harmful effects of giving of hyperoxia, as well as just oxygen in non-hypoxic patients. So obviously you need adequate cellular oxygenation for your cells to work. Low oxygen sats can be life-threatening, especially in acute conditions, which is why oxygen is one of the first things we apply when we go to resuscitate a patient. So the idea is if you give oxygen, you're going to increase oxygen delivery, you're going to prevent tissue hypoxia and cell death. But the harm with oxygen, I thought, is really nicely described by this review article by Jean-Louis Vincent, looking at how it's much more U-shaped. It's not just hypoxia is bad, but as you get up on to the left-hand side, you see the hyperoxia is harmful to cells as well. And there are certain physiological conditions where we may be exposed to hypoxia in nature. So whether you're at altitude, whether you have pulmonary disease, or some other reason, throughout the life cycle, humans may experience hypoxia. But there's no natural situation where you're going to encounter hyperoxia. It's only going to be iatrogenic. So the clinical settings in which oxygen toxicity occurs is mostly divided into acute and chronic. So the acute effects are more seen on the left-hand side, which tend to be more CNS effects. So toxic effects, so on enzyme cells, your central nervous system, leading to twitching, convulsions, and destruction of neurons. So this is predominantly this is the Burt effect, named after Paul Burt, who just mostly discovered it. And then chronic toxicity, which tends to be when you get low levels of oxygen, which is what we give to most of our patients in hospital, causes more pulmonary effects, or the Smith effect after Lorraine Smith. So the biochemical basis for the effects of hyperoxia is the formation of oxygen-free radicals. So you have one or more unpaired electron that makes them very unstable. And the most biologically significant of these reactions is this one here. So the combination of the superoxide free radical with the nitric oxide results in peroxynitrate, and that is very damaging to lipids, proteins, and nucleic acids, which results in cell death and necrosis. So obviously our body has antioxidant systems, but with high concentrations of oxygen and the generation of free radicals, these get overwhelmed. So let's move away from the theoretical and into the clinical domain, looking in closer detail at the use of oxygen in cardiac arrest, myocardial infarction, severe traumatic brain injuries, and ischemic stroke. So what's normal? Well, it depends on your age and your altitude, but in general, oxygen saturations of 94 to 98% would be normal for most adults living at sea level. So if that's what you're going for, you're probably going to hit normal most of the time. So when we look at the use of oxygen in cardiac arrest, different phases of the rest have to be looked at, so both the intra-arrest period and the post-ROSC period or post-arrest period. So this very nice retrospective study of 255 patients looked at in-hospital cardiac arrests. The arrests were very similar in terms of where they happened, so ED, cath lab, ICU, the general wards, as well as the duration of CPR, the initial rhythm, and all those things for comparison. And they basically split the patients into 5 groups based on what the PaO2 was at the first ABG during the arrest. So I only know partial pressures in millimeters of mercury, so I apologize if you think in kilopascals. So with respect to the outcomes, they showed quite nicely that if you had higher intra-arrest PaO2, you had a higher survival you had higher rates of ROSC and higher survival to hospital discharge, as you can see from the arrows there. So people with a low PaO2 down at far left of less than 60 had a ROSC rate of about 58%, while getting up to 100% with a very high intra-arrest PaO2. When they did multivariate analysis of that, they showed that a PaO2 greater than 300 millimeters of mercury was independently associated with higher survival to discharge. So the conclusion drawn from this study was that a higher intra-arrest PaO2 is independently associated with higher rates of survival to discharge in adults who have undergone an in-hospital cardiac arrest. However, it's not clear whether the low PaO2 is due to suboptimal quality of CPR, underlying disease, higher severity of illness, or suboptimal ventilation or perfusion. And as well, the other things that wasn't clear from the study is when in the arrest the ABG was taken. So was it taken at the beginning of the arrest when the patient is probably arrested and they're well oxygenated, as opposed to later on in the arrest? So those are two confounders when you're looking at the results of this study. So oxygen use post-ROSC. Well, lots of studies have looked at this, and they've shown that after you've been resuscitated, if you remain hyperoxic, you have a worse outcome. Recently, this year, the last study was a meta-analysis that incorporated all these studies that have been done over the years and looked at both intra-arrest and post-ROSC hyperoxia. And they showed that intra-arrest hyperoxia is associated with a better outcome, while post-arrest hyperoxia is associated with a worse outcome. So you need to turn the oxygen up and then turn it down, was the conclusion that came from that. In order to look at this further, so Paul Young, who's a Kiwi, who's a very prolific researcher in Australia and New Zealand, started a trial called the HOT or NOT trial with the ANZIC's clinical trial group, trying to look at maintaining SATs of 90 to 94% post-ROSC in the community in adults who've had either a VF or a VT out of hospital cardiac arrest, as opposed to normal management. Unfortunately, they randomized about 17 or 18 patients, and the study was stopped early by the Data Safety Monitoring Board because quite a few of the patients in the intervention group, so when they're trying to keep their SATs 90 to 94, were actually found to be much lower SATs, so about 88, so they didn't think that it was ethical to go on, and so the conclusion that they drew was it wasn't feasible. However, the EXACT trial, which is ongoing still, did a pilot study to demonstrate that it is feasible. So the EXACT trial will help us answer that question, and as well as the REOX-2 trial, which was looking at reoxygenation after cardiac arrest, should be coming out sometime this year, which will also be really interesting. So that's arrest. So moving on to people who are having acute coronary syndromes. So the AVOID study found that in patients who've had a STEMI or an ST elevation MI who are not hypoxic, there was a suggestion that potentially oxygen is increasing the size of the myocardial injury, could increase the risk of recurrent myocardial infarction as major cardiac arrhythmias and be associated with greater infarct size. So interestingly, this was actually demonstrated more than 40 years ago in a very different patient population that I see in my CCUs of, you're not allowed in CCUs back in the 70s unless you're less than 65. So when we look at the use of oxygen in acute coronary syndromes, there's obviously a balance between hyperoxia and hypoxia. So you want to make sure that the ischemic myocardium is being perfused, but at the same time, oxygen itself is a vasoactive substance that causes vasoconstriction, it increases your afterload, and has been shown to reduce coronary blood flow, which isn't great for the ischemic heart. So the European Resus Council guidelines, which are similar to guidelines from ILCOR and the American Heart Association, is that as soon as you should give oxygen, but as soon as you can accurately measure oxygen, either through arterial blood glass or through pulse oximetry, you should titrate your oxygen to SATs of 94 to 98%, I think, and to avoid hypoxemia. So moving on to traumatic brain injuries. So we've already had a little introduction this morning to the secondary brain injuries, and when we talk about people with severe TBI becoming hypoxic, we know reduced cerebral oxygenation can be associated with impaired mitochondrial function and reduced metabolic rate, and associated with an increased risk of secondary brain injury. So theoretically, treating such patients with hyperoxia may be good for their brains. So lots of studies have attempted to look at this. They have all had conflicting results about outcomes. Most of these have been retrospective reviews. There was a small randomized control trial done of 68 patients with severe TBI who received either 80 or 50% oxygen via mechanical ventilation in the first 6 hours after their injury. And they showed that patients in the hyperoxia group had better outcomes at 6 months using the Glasgow outcome scales. So don't know what to do, the jury's out on TBIs. So similarly, in ischemic stroke, the evidence is conflicting. So different authors have shown different things. So Young showed no association between the worst PaO2 in the first 24 hours after ICU admission and mortality in patients with acute ischemic stroke, but other observation studies have shown detrimental effects on short and long-term outcomes. The biggest study done, the stroke oxygen study, which included more than 8,000 patients, showed that there's no difference between mild hypoxia and hyperoxia post-stroke. So the British Thoracic Society has released guidelines. This quote's an article that's 10 years old, but the guidelines are roughly the same about the use of oxygen in adult inpatients. This is a very truncated version of the slide. It goes through decision-making based on ABGs, but just the crux of it is, if the patient is about to die, give them oxygen. And then if they're not, you can have a think about it. So are they at risk of hypercapnic respiratory failure? So COPD, those typical patients we see, if so, you should aim probably for SATs more of 88 to 92%. If they're not, again, no one needs SATs of 100. Titrating SATs of 94 to 98% are adequate. That being said, there are a few special situations. So obviously in carbon monoxide poisoning, sickle cell crisis, or diving emergencies, it is reasonable to give them more oxygen, particularly in carbon monoxide poisoning when your monitoring is essentially useless. So your SATs are going to show 100%. Even though your PaO2 on your gas is fine, you still have tissue hypoxia. Sickle cell crisis, the recommendations are to go for what's normal for the patient because hypoxia may aggravate sickling. And then similarly, on the other side of the chart, where you might not give supplemental oxygen even if the person was hypoxic, would be people with bleomycin exposure or paraquat poisoning because it increases reactive oxidative species generation. So I think about this as Goldilocks and the 3 rules of resuscitation. So I hope you know what Goldilocks is. That's not a North American thing. So you don't want to give too little. You don't want to give too much. So assume nothing. Trust no one. Titrate the oxygen. Thank you very much.